Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Klebsiella species under the section of infectious diseases. So this is the picture of Klebsiella oxytoca. It's not very common for MRCP to ask you about histology or microbiology slides. However, they are within their rights to still ask you some of these questions as part of the written exam in part 2. So I would have a broad idea of putting this into mind of what the common bacteria and histology slides would look like for different diseases. So the epidemiology of Klebsiella is that it is one of the most important nosocomial infections. Occasionally, it is transmitted in the community, and it has a high prevalence in terms of the patients who are in intensive care units and among patients who receive long-term care. The pathophysiology of it is that it is a gram-negative, facultative, non-motile, encapsulated, rod-shaped bacteria. It is commonly found in environment and normal flora of the human gut. It has a thick polysaccharide capsule, which is a key virulence factor, and it competes with host for iron, which is crucial to its survival and pathogenicity. The clinical manifestation of Klebsiella is quite varied. Classically, it can present as a cavitating pneumonia called Klebsiella pneumonia, and that's one of the important differential diagnoses that you need to be providing the examiner as one of the causes of a cavitating lesion in the lung. It can also affect the biliary and gastrointestinal systems, resulting in septicemia and liver abscesses. It can also sometimes cause urinary tract infections. However, these are really common in those with indwelling catheters, and it's really uncommon in somebody who doesn't have a catheter. And it can also cause nosocomial infections, as previously discussed. The management of Klebsiella really is through A, thinking about the diagnosis, B, diagnosing it through the correct culture medium, which is using the McConkey agar. PCR and other nucleic acid amplification tests can detect resistance genes. Typically, it's resistant to amoxicillin, and it will frequently require carbapenems for severe infections. Multi-drug resistant is a challenge, which is unfortunately becoming more and more common, and this may need combination therapy with colistin, tigecycline, or newer bacteria lactam agents. Let's do some questions. A 65-year-old woman with diabetes mellitus is admitted to the hospital with symptoms of high fever, chills, and flank pain. She has a history of recurrent urinary tract infections. A urine culture is positive for Klebsiella pneumonia, which is found to be resistant to multiple antibiotics, including third-generation cephalosporins. Which of the following is the most appropriate initial treatment for this patient's infection? A. Oral trimethoprim sulfamethoxazole. B. Intravenous ceftriaxone. C. Oral ciprofloxacin. D. Intravenous meropenem. E. Oral amoxicillin. So this is quite a standard case of somebody coming in with a history of UTIs, coming in with what sounds like another urinary tract infection that is positive for Klebsiella pneumonia. It has previously been found that it's resistant to third generation cephalosporin, and if you remember, We did discuss that oral amoxicillin is not going to be good enough in the cases of Klebsiella. Therefore, options B and E would be incorrect. Option A is also incorrect given the fact that this patient is clearly very unwell and in sepsis. So you would need to be opting for something that is intravenous, and therefore option A and C would be incorrect. And even if you hadn't known this by choice of elimination, you should be able to get to option D, which is intravenous meropenem. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.